me. I have to go through all of these again, I guess. Okay, so continuing where we left off with meningitis. So symptoms of meningitis are quite similar in both viral and bacterial. You're going to see a severe headache, drowsiness, delirium, irritability. So they're kind of confused, they're very restless, they're going to have a fever, vomiting, nuchal rigidity, which is also known as stiffness in the neck, which most people would notice this as a sign, okay? Because really, a lot of these other things can be other illnesses as well, but that nuchal rigidity is a pretty tall tale sign for meningitis, but it is also not always present, so keep that in mind. A high-pitched cry in an infant or a child. Seizures are common, and then they can even potentially go into a coma. Diagnosis of meningitis is confirmed by exam of the cerebral spinal fluid. Okay, so they do a spinal tap similar to lumbar puncture. Difference in characteristic based on bacterial or viral. So you're going to see different things when you do this tap, and it's going to look different if it's bacterial versus if it's viral. The treatment for meningitis is droplet isolation until 24 hours after the appropriate antibiotics have been started. We do give steroids for bacterial meningitis, and we can also end up giving them anticonvulsants because they can have convulsions, and so it's important that we prevent that from happening. A big responsibility for us as nurses is to perform neurological checks. We're going to make sure that we are doing this as ordered, and we have to report any abnormal findings. So weakness of the limbs, speech difficulties, any mental confusion or behavior problems, we need to report immediately. We need to make sure that we are documenting accurate vital signs and intake and output. And then, of course, we want to maintain a quiet environment. Somebody that has meningitis does not want to be overstimulated. This is just a kind of a cool little slide that can help in determining meningitis. So the Kernig sign is a knee extension. Okay, so as you can see there, the patient is laying flat, so they're supine and they have their hip flexed 90 degrees, so that knee cannot be fully extended. So this is known as the Kernig sign. If they do fully extend, there's a lot of pain. The other one is called the Brudinsky's neck sign, and this is neck rigidity. So it's, again, they're laying there, both hip and knees are flexed, and if the neck is being flexed, they bend their neck and their hip and knee flex. Okay, so that's a nice little mnemonic there. So with that Brudinsky sign, neck flexion leads to knee flexion. So you can kind of see an outline of the feet. So that's how we're starting out. But if we pull up their head and flex their neck, then their legs are going to also go up. So that's another sign. So you guys should know these signs. Encephalitis is a little bit different than meningitis. Meningitis is the inflammation of the meninges, which is that covering of the brain and spinal cord, whereas encephalitis is inflammation of the brain itself. So not the meninges, but the brain alone. Inflammation on that brain, also known as encephalomyelitis, when the spinal cord is also infected. So encephalitis is the brain, but encephalomyelitis is including the spinal cord. Symptoms result from the CNS's response to irritation. So headache followed by drowsiness. They can end up going into a coma again. Convulsions. We're going to see that especially in infants. We're going to have fever, cramping, abdominal pain, vomiting. Again, that nuchal rigidity, so that neck pain, delirium. Their muscles might start twitching, and we might see some abnormal eye movements. Causes of encephalitis include bacteria, different kinds of bacteria, spirochetes. So examples of spirochetes would be syphilis or Lyme's disease. Lyme's disease you can get from a tick bite. And then viruses, such as MMR, varicella, and herpes. So again, it's really important that we educate on getting those vaccinations, because if we get those, we can help prevent the likelihood of getting encephalitis. Treatment is supportive. It's aimed at providing relief from the symptoms, okay? Sedatives, so keeping them calm and not overactive. Antipyretics can also be ordered. Seizure precautions are obviously going to be taken. We want to provide adequate fluid and nutrition to the patient, and if we notice that their oxygen saturation is starting to go down at all, we can supplement oxygen as well. Some seizure disorders, the etiology varies on these, so it's not always a one fits all, but it's the most commonly observed neurological dysfunction that is noted in kiddos. It consists of a sudden intermittent episode of an altered level of consciousness that lasts seconds to minutes, and it can include involuntary tonic and clonic movements. And we did talk about that earlier on in the semester, those tonic and clonic movements. Some causes of seizures in kids, intracranial seizures, we've got epilepsy, we have congenital anomalies, maybe a birth injury, infection is possible, trauma, degenerative diseases, and vascular disorders as well. Epilepsy, if you are not sure of what that is recurrent paroxysmal, which is sudden or periodic, attacks of unconsciousness or impaired consciousness that can be followed by tonic movements or like contractions, or clonic movements like relaxation. So this results in alternating those tonic and clonic movements of the muscles. The most common type of a seizure that you will see in children is a febrile seizure. So it's a seizure that's caused by a sudden rise in the body temperature because of potentially inflammation or infection. Extracranial signs that we might notice would be fevers, heart diseases, metabolic disorders, hypocalcemia or hypoglycemia, and dehydration and malnutrition. So these are reasons for extracranial seizures. Toxic would include anesthetics, poisoning, drug use, those types of things. So think about what potential poisons or drugs that a child could come into contact with. All right. Generalized seizures, we've got tonic-clonic seizures. That onset takes place without warning. It's the most prevalent of the seizure types. Um, the focal, we've got seizures with motor manifestations and sensory manifestations. And then unclassified is nothing that you guys really need to worry about. Just know that febrile seizures are the most common when it comes to children having different types of seizures. You can also refer to page 71 in your ATI pediatric book. So nursing care, we're going to make sure that the side rails of the bed are padded, whether it's on a bed or a crib, even a wheelchair. We want to keep a bed free of objects, so we don't want anything in there. We should always have suction and oxygen available if needed, just because you never know and you might run into that. Now, that being said, this is obviously something that you would have available if a patient has had a seizure historically. We don't just keep these available for all kids and babies at their bedside. During a seizure, if they're on the floor, we want to make sure and put a blanket under their head, because when they're seizing, we don't want their head to repetitively be hitting a hard floor. Want to make sure we maintain a patent airway, so that's huge. Turn them to their side lying position. Now, why would we do that? Obviously, it's going to be to prevent aspiration and make sure that we are draining those oral secretions that develop. So we don't want them to be choking on any of that. We should not attempt to open the jaw, insert an airway, or put anything in the mouth during the seizure, because again, they can end up choking on it. They can end up biting down really hard on it, breaking teeth, those types of things. So it's not advised to do that. You always want to remain with the child, and you want to note the onset, the time, and characteristics of that seizure. So what did you notice? What kind of symptoms were presenting? How long did it last? When did it start? When did it stop? And the biggest thing is remaining calm and reassure the caregivers. So we want to just make sure that our demeanor is calm. Obviously, that's very scary in those situations. But if we are scared, we're going to scare the patient and we're going to scare the caregivers as well. Post-seizure, we should maintain that side lying position. Again, we just want to make sure that we are preventing choking on anything. We should be checking their breathing, their vital signs, the position of the head and their tongue. That tongue we don't want to flop backwards, because then that can cause them to have difficulty breathing, or it can also choke them as well. We want to perform neurologic checks. We want to reorient them and kind of try as best as we can to calm them down, because they have no idea what just happened, and that's very scary for them. We should note the time of the postictal period. So again, when did it end? We should not offer food or liquids until they are completely awake and swallowing reflex has returned. Sometimes after a seizure, it can take a little while for that reflex to come back. And so we want to make sure that we are not giving them anything if that has not returned quite yet. We're going to encourage our child to describe the period before, during, and after. That will help us with treatment. That will help us to recognize things for the future and give us a little bit better of an idea of what it is that they experienced. Okay, so education regarding seizure triggers for infants and for children. Flashing of dark and light patterns kind of makes me think of strobe lights, how they just flash so quickly and it just kind of can mess with your head a little bit. That can actually be a trigger. Quick startling movements can be a trigger for seizures. Overhydration, so actually being too hydrated. Photosensitivity, so maybe quick flashes of light, and then suddenly stopping medications. Medications should not be suddenly stopped. We want to make sure that parents know that and that they should first get the clarity from the provider to do so and the okay to do so, and education on how to slowly wean off of those meds. Determining the type, the site, or the cause of the seizure is very important. There's multiple diagnostic techniques that we can use for this. So it might be a CT, it might be an MRI, it might be an EEG. And with all of those methods, we have to educate on PrEP. So sometimes that looks like using a certain type of soap to clean our body the night before. That might look like not eating or drinking so many hours before the scans. Lab tests are used to rule out poisoning or electrolyte abnormalities. So we can look at a white count. We can look at a patient's glucose level, metabolic panel. So that's checking their electrolytes, and then toxicology. So is there something toxic in their blood? Drug of choice and surgical treatment depends on the type of seizure. So we can't do that until we know what it is that caused it. So our big goal is to control with the least amount of medications at the lowest dose, okay, with the fewest side effects. So their body went through a lot. So now we have to consider the least amount, the lowest dose, and the least amount of side effects. Diet changes may be needed for patients who do not respond well to anticonvulsants. And actually, the ketogenic diet is one that is recommended for seizure treatment. And why that might be your question, the ketogenic diet, if you're not familiar with it, it is high in fats and it's low in carbohydrates. So it produces ketoacidosis, which appears to reduce those convulsive episodes. It's kind of interesting how that works. So making sure that we are maintaining seizure precautions is crucial. We need to keep our side rails up. We need to pad all sharp or hard objects around the bed. Making sure that the child wears a medical ID bracelet is really important, because that way we're aware that maybe they've got something going on. We need to provide supervision during potentially hazardous play, such as swimming, because if a child has a seizure while they're swimming, they could drown. Avoid triggering factors. So if we know what's caused a seizure in the past, we want to avoid that at all costs. And then teach the importance of compliance with medication. So if we aren't compliant with our seizure medications, we could end up having it again. We could have worsening seizures, and that can cause long-term effects. So here is an example for you guys of tonic and clonic seizures. So with that tonic, they're extending their legs and their arms are pulled in. Whereas with the clonic, you can see that the legs are pulling in and jerking. So tonic is more of the stiffening, they're stiff like a board, and clonic, you're going to see more of that muscle jerking. Hydrocephalus, okay, that's also known as water on the brain. It causes ventricles to enlarge and pressure to build against the skull because of the excess fluid. So as a result of that, we have inflammation taking place. We can see brain tissue damage, and it can also be life-threatening if it is not treated. So as you can see here on this picture, obviously the expected head shape is at the top, and then we can see in the bottom left how it's starting to grow, and it's significantly grown on the bottom right. Oh, I'm sorry. So the etiology is buildup of that cerebral spinal fluid, and this happens if there is a blockage that's presenting that prevents that cerebral spinal fluid from flowing. It can occur if there's a decrease in the ability of neural blood vessels to absorb that fluid, or it can occur if there is an excess amount of it being produced. So this does actually have a strong genetic link. Hydrocephalus is also associated with certain neurological developmental disorders such as spina bifida, encephalocele, excuse me. And what an encephalocele is the neural tube doesn't close in the brain, so then there is a protrusion. Just a quick little story. We had a baby come into the clinic, and it was his 6-month well check, I think, and we measured his OFC, and his head circumference was quite a bit larger than it was at his 4-month visit. So he ended up having to have a scan done. It turned out that he had hydrocephalus, and it continued to grow and grow and grow, and shortly after 1 year of age, he ended up passing away. So clinical presentations of infants, you're going to see a large head size with that increased head circumference, bulges in the fontanelles, so remember the anterior and posterior fontanelles, prominent scalp vasculature, so that means we can really see the veins in the head. Their eyes might be downward deviated, so think about all that pressure up there. Would make sense that your eyes deviate downwards naturally. They're going to be fatigued, irritable. You're going to see seizures, vomiting, some low muscle tone. Clinical presentations in toddlers, in older children and adolescents, you might see nausea and vomiting, headaches, some vision trouble, difficulty waking or even staying awake. We can see a poor appetite, some balance problems, irritability, difficulty with concentrating or simply can't concentrate at all, and then hearing loss. Usually we see hydrocephalus in infants and children. So what kind of diagnostic tests can we do? We can do neuroimaging. So an ultrasound can be done to detect enlarged ventricles in the fetus. So we can actually do that while the baby is still in utero. A fetal MRI can also be done, and then we can do a lumbar puncture to check that cerebral spinal fluid, especially if that meningitis is suspected. The treatment of hydrocephalus focuses on restoring the expected flow of cerebral spinal fluid and reducing pressure on the skull. Most common treatment is a shunt that directs the flow of cerebral spinal fluid from the brain to the abdominal cavity where it can be reabsorbed into the body. I actually know somebody as an adult that for some reason, her cerebral spinal fluid picked up in accumulation, and she was having headaches, she was having vision changes, and it got to the point really rapidly for her where she couldn't see anymore. And it was because of the amount of cerebral spinal fluid that was accumulating. And so she ended up having to have a drain placed in her brain, or a shunt in her brain, that allowed that cerebral spinal fluid to flow from her brain into her stomach, and it just absorbs, the body just absorbs it. All right, so spina bifida. This is a neural tube defect, and it's present at birth. It's characterized by failure of the osseous spine to close with central nervous system effects. A congenital embryonic neural tube defect with an imperfect closure of the spinal vertebrae is what happens with this. So you can see spina bifida occulta, which is hidden, so you can't see anything, or you can have spina bifida cystica, which is a sac or a cyst that actually bulges on the outside. This information is in chapter 28 of your ATI PEDS book as well. All right, so spina bifida occulta affects the lumbosacral area, so it's not visible externally again. Surface of the vertebral bone is missing, so there's no spinal cord involvement with spina bifida occulta. You might notice that that infant has a tuft of hair, a dimple, or a lipoma at the site. Treatment generally is not necessary unless neuromuscular symptoms appear. And then when we look over at the spina bifida cystica, we notice that there is a protrusion of the sac visible on the outside. So meningocele is a sac that contains spinal fluid and meninges. Okay, sizes for this can vary. There's an increased risk for infection if this ruptures, obviously, but it does not produce any neurologic deficits. A myelomeningocele is actually the most common form of spina bifida cystica, and it's a sac that contains spinal fluid, meninges, and nerves. Okay, so the big difference there is the meningocele has spinal fluid and meninges. The myelomeningocele has spinal fluid, meninges, and nerves. So this is a more serious protrusion of membranes and spinal cord through the opening. It is possible to have paralysis of the lower extremities associated with this. And with that decreased motor and sensory function, we can also see poor or even no control of the bladder and the bowel. Okay. Hydrocephalus can actually be a common complication related to spina bifida. So it's good to know that. All right, so here is an example for you. I like this visualization. Picture A is spina bifida occulta. So as you can see, there is like a little tuft of hair present there. But you can see the spinal canal and you can see the meninges. And then there's that small defect in the bony canal. Okay. Now when you look over at B, you see the spinal cord. You see the defect in the bony canal. And then there is that meninges that's protruding. Okay, so this is that spina bifida cystica or the meningocele. Now picture C is even more extensive because as you can see in kind of that bulge that's pressing out, there is meninges and spinal cord protrusion happening there. Okay, so that's spina bifida cystica myelomeningocele. It's good to know the difference between these, the occulta, the meningocele, and the myelomeningocele. With the occulta, we don't see anything necessarily besides maybe a dimple or a little tuft of hair where that's at. With the meningocele, we see the meninges protrude, and then with the myelomeningocele, we're seeing meninges and spinal cord components protrude. So that's the biggest difference with that, along with obviously the signs and symptoms. So how do we prevent spina bifida? It's important for the mom to take folic acid, 0.4 milligrams per day prior to becoming pregnant and or continuing to take that folic acid supplement until the 12th week of pregnancy because that is when they are rapidly growing. Just some little tidbits on the side there. Some foods that contain folate include beans, lentils, citrus fruit, and leafy green vegetables. And then 50 to 70% of neural tube defects, such as spina bifida, can be prevented with folic acid. So there's good history and study backing that up. Folic acid can be taken orally too, just so you're aware of that. What kind of prevention or, treatment, sorry, I should have said treatment, can we do for spina bifida? Sometimes we have to do surgery to close it. And the prognosis of it is really just dependent on how much of the spinal cord is involved. So you can see a picture here. This would be an example of a myelomeningocele because there is actually meninges and spinal cord in there. So what do we want to do to care for this? We want to make sure and prevent infection of or injury to that sac. We want to make sure that we do correct positioning so that we don't have pressure on the sac. Now that's going to be really hard to do with a baby like that, right? A lot of babies, we want them to lay on their back, but this baby in particular would not be able to do that because of that large sac on their backside. We want to prevent development of contractures. We want to make sure we maintain good skin care, have adequate nutrition, observe them very closely and make sure that we're charting everything, and then educate the parents on the importance of how to care for their baby. We're going to make sure that we continue with supervision. And as far as infection with that sac, how could we prevent it? Well, if a baby is born this way, it's important to take like a moist, sterile towel and cover that up. Okay, and that will help with prevention of bacteria. So you should know that. It's very important to make sure that we keep that sterile dressing over the top of that sac to try and prevent any complications such as bacteria forming. They are placed under an incubator when they are born. We need to make sure and maintain their temperature. Again, here's reiteration of that moist sterile dressing on that sac. Protection from injury and maintenance of a sterile environment is very important. And then we're looking at that sac to see, are there any tears? Is it leaking from anywhere? We need to make sure and observe the extremities. Did this sac cause any deformities? Are they able to move their legs well? We're going to measure their head circumference because, again, if you remember, hydrocephalus is related. And then the fontanelles are observed to provide a baseline for future assessments moving forward. Cognitive impairment. Elements involved in mental functioning, we're going to look at level of consciousness, their thought processes, and expressive language. Just a little information for you. The typical IQ of a child that has intellectual and development disabilities is usually below 70. Okay. A genius is someone that's considered to be above 140. So if you think about Einstein, he had a very, very high IQ. His was 160. So there's different aspects involving mental functioning. We look at the level of consciousness. So with that, what's their attention look like? Do they have a short-term or a long-term memory? Or do they have both? What is their perception of life? With a thought process, we're looking at their insight, judgment. How can they judge things? And what's their affect look like as well? How do they react? How are they acting on a certain day? What's their mood like? An expressive language would be vocabulary. Do they have abstract thinking? Are they intelligent? The American Association on Intellectual and Developmental Disabilities, again, that can be mild or severe, and an IQ of someone that is intellectually impaired is typically below 70. So there's different types of testing that can be done to measure intelligence. They have what's called the Stanford Binet test. This is an examination that gauges intelligence through 5 factors of cognitive ability. So the 5 factors include fluid reasoning, knowledge, quantitative reasoning, visual spatial processing, and a working memory. They look at their verbal and nonverbal responses. So they kind of weigh the factors, each of those 5 factors, and the combined score is often reduced to a ratio that's commonly known as that IQ. All right, so limitations in at least 2 of the following is what somewhat classifies somebody depending on their intellectual impairment. So how is their communication? How is their self-care? What does their home life or their living look like? Do they have social skills? Do they utilize the community? Can they direct themselves or do they need somebody to direct them? Their health and their safety. What does that look like? Are they aware of safety precautions? Are they aware of what it is to maintain health? Functional academics, and then their leisure and their work. So again, limitations in at least two of the following. Oftentimes it's more. So some causes of intellectual impairment can be during that neonatal period. So they can develop PKU or phenylketonuria, and what that is a rare, pretty rare metabolic disorder and that's inherited, and it affects the body's ability to break down an amino acid known as phenylalanine. Okay. Hypothyroidism in that neonatal period can be a reason for intellectual impairment. If somebody has fetal alcohol syndrome or FAS, Down syndrome, maybe malformations of the brain, or maybe that mom had an infection when she was pregnant, and that's a cause of intellectual impairment. Birth injuries or anoxia during or shortly after delivery can also be reasons. Okay, so anoxia, they're not getting enough oxygen to that brain. Some hereditary or childhood causes would be meningitis, if they develop lead poisoning, some neoplasms, encephalitis, and then living in a physically or emotionally deprived environment. So if a child is deprived of care, if they don't get love, those types of things can actually have a factor on intellectual impairment as well. So how can we help these kids? What's success look like for the intellectually impaired child? We need to assist parents in understanding that providing experiences that they can be successful in and concentrating on their strengths rather than their weaknesses is extremely important. Okay, so we are not going to hound them about what they're doing wrong. Rather, we are going to celebrate with them about what they are doing right or what they are very good at. So a child that experiences constant failure and doesn't do good typically becomes angry. So that anger can cause behavior difficulties, and that can cloud the problem and therapy as well. Okay, so an example that you could use for a parent to be helpful to their child in becoming successful would maybe be giving them more positive feedback instead of hounding them all the time, or allowing that child to do some of the things that they really love and that they feel like they're good at and praising them. So management and nursing goals with the intellectually impaired, we're going to have an individualized plan of care. So this is not a one fits all. The initial step is to prevent the findings or what we observe to the family, and then we need to be supportive emotionally to them. That can be difficult for them to get that type of news. And so we want to do the best that we can to provide support. The competence and adaptive behaviors of that child should be discussed along with deficiencies. So, what do they do well? How do they adapt? What's the best method for adapting? Are they competent in doing X, Y, Z? And then we're looking at their deficiencies. So, what maybe do they not do as well in, or what is something that could negatively affect them? So if a child is in the hospital, the nurse should be obtaining the child's stage of maturation and their ability, self-help activities, and home routines. So that's all important in how this child will develop. When we look at the child's stage of maturation and ability, what we're looking at is, are they meeting those developmental milestones for somebody their age? Or are they maybe meeting the milestones of somebody that is several years younger than them? So if we play therapy, it helps to nurture growth and development with that kid. So that's a great way for a nurse to assess their stage of maturation and ability. Discussing self-help activities is also a great thing with that child. So we can talk to them about personal hygiene, about making meals, maybe doing chores or toileting or walking. These are all things dependent upon age of how we can help them. So nursing responsibilities to disabled children, we want to emphasize their strengths that are present. Again, really um, hitting home with that we want to praise them for what they're doing well. We want to maintain communication with family, so making sure that if we are having a bad day, that everybody's aware of that and, not trying to make it worse per se. We want to avoid using labels, rather using simple terms. So making sure that terminology is used appropriately is important. We can contact the school nurse if we need to and plan for school needs, provide daily experiences for their success. And then there are also different support groups that can be presented for somebody that has an intellectual impairment. All right, shaken baby syndrome. This is roughly shaking an infant that causes the brain to strike the inside of the skull. So it causes tearing of the nerve fibers within the brain. Okay. Infants who are roughly shaken can sustain retinal, subarachnoid, and subdermal hemorrhages in the brain, as well as cervical spine injuries because of those tearing of the nerve fibers in the brain. It can result in permanent brain injury, even death. Okay. Symptoms can include a headache, so manifested as fussiness, obviously in a toddler or a baby, drowsiness, blurred vision, vomiting, dyspnea, so difficulty breathing. In severe cases, a child may be completely unconscious. Um, Shaken baby syndrome often occurs when a parent is extremely overwhelmed, or a caregiver or whomever it may be. They become very overwhelmed. Maybe a baby's been crying inconsolably and you have tried absolutely everything and you just can't handle it anymore. So making sure that we teach parents or caregivers how to cope and the different types of techniques that can be used for coping can prevent this type of injury. This is some posturing that you might see in brain injury. So the top one, A, that's decorticate, which is that flexure posturing. So they're flexing. The arms and the wrists and the fingers are all flexed, and then the plantar flexion occurs in the feet. Okay, so the feet are kind of pointing forward, I guess you could say. This indicates cortex damage in the brain. B, that picture of B is decerebrate or extensor posturing, and all four limbs are extended and hands are pronated, like you can see in that picture. And this actually indicates a brainstem injury. So both of these indicate different things. The first one is decorticate posturing, and it indicates cortex damage. And the second one is decerebrate posturing, and it indicates brainstem damage. So how can we observe child for signs of increased intracranial pressure? There's 4 components of a cranial or neurological check. We're looking at the level of consciousness, the pupil and eye movement, vital signs, along with motor activity. What kind of care are we going to provide? Subtle clues to change can be missed unless the nurse performs aggressive assessment and looking for them. So we have to make sure that we are looking very closely at this child. Okay. The lack of the child's ability to communicate and cooperate makes it hard. Okay. It can pose a challenge in that neurological assessment of infants, but knowing and having knowledge of normal growth and development helps the nurse evaluate the status of the patient. So while the last 2 units were maybe a little stressful for you, it is beneficial because having that knowledge can help in determining where they're standing. So monitoring neurological status in infants and children, we're going to look at their pain stimuli response. So do they respond to pain? What is their level of consciousness? Is it easy to arouse them, or is it difficult? Cranial nerve response, motor response, posturing. What's the pupils look like, or what are the pupils doing? Do we see bulging fontanelles? Is there scalp vein distension? So can we really see those scalp veins? Ataxia, specifically of lower extremities, and then the moro and tonic neck with withdrawal reflexes. Okay. I'm just going to briefly touch on the Glasgow Coma scale. This is a scale that is used to give a reliable and objective way of recording the conscious state of a person. Okay, so this can be done for an initial assessment or a follow-up assessment, and they are assessed against the criteria of the scale, and the resulting points give a patient a score between 3, which is considered a deep unconsciousness, and 15, which is more widely used. The Glasgow Coma Scale was initially used to assess level of consciousness after head injury. We use it as first responders, nurses, doctors, to help indicate different types of trauma. This is often used in the ICU or in the intensive care unit as well. This just provides an example of a Glasgow Coma Scale. Similar to other scales you've seen before, we have a score, so we have numbers along the side, and then we're looking at the behavior. So for example, the eye-opening response. If they open their eyes spontaneously, they get a 4. If they only open their eyes to someone talking, they get a 3. If it's to pain, 2, and no response is a 1. So you add those up, and then that will give you a total score on the very bottom. So best response that we're going to see is 15. A comatose patient is considered a score of 8 or less, and then totally unresponsive would be a 3. And that ends this lecture.